So now it's time to move on to our next session on acetabular defects. I invite Professor Arora sir for his talk. At the same time, I invite Dr. Subhash and Dr. Sanjeev Jain to chair the session, Dr. Sanjeev Kumar and Dr. Adit Narula to be the panelists.
So my talk is on TH in protusio.
Sanjeev
Dr.
Jain.
Vishal, Dr. Vinay for inviting me here. So protusia stabili is not an uncommon condition, and you require total lip arthroplasty at end-stage arthritis. So total lip arthroplasty. So when do we call protusio? If the femoral head is medial to cochlear line, then protusia is present. And it could be of various grades. You can see in simple X-ray, no issue at all. But if you're suspecting a breach in the floor or medial wall defect, you need a CT scan, otherwise X-ray is good enough for you to plan the case. What are our aims of management? Number one is to reshape the acetabulum, which is divergent, to make it convergent, strengthen the wall, the medial wall, restore the bone stock, achieve cup stability on a stable, bony bed after grafting, and restore the biomechanics of the cup by lateralizing and inferiorizing if required with the use of bone grafts or augments, create normal center of rotation, restore femoral offset, and soft tissue balancing. And as a usual case, we do templating, and in templating, the most important aspect is where you want to place your cup, where is going to be center of rotation. This morning, we had a lot of discussion on the so-called high hip center. Now, where does the normal cup lies? The normal cup lies in an isosceles triangle, which is 20% of the pelvic height. Is Ranavat's method. It is 20% of the pelvic height with its inferior margin, about 5 millimeter lateral to the intersection of Coles line and Shenton's arc. This is the normal area of the socket, and the center of this arm is the normal center of rotation. You be prepared with the so-called enhanced porous surface cups, which has better osseointegration, multi-hole cups. If there is medial wall defect, be prepared with anti-protusive devices. Have bone grafts with you. Have image also, if required. Exposure, majority surgeons prefer posterolateral approach. Beware, sciatic nerve is very close to the trochanter, and in case of severe protusio, you might require extended trochanteric osteotomy for exposure. For dislocation of hip, do circumferential excision of the capsule and remove all the osteophytes which are impinging onto it. No forceful rotation for dislocation. Don't ask your associate to dislocate. Use a bone hit to take it out. And you might require psoas or tenotomy to take the head out. In case it is severe protusio, you don't want to take the head out, you need to go ahead and do an in situ neck osteotomy. Beware, don't damage the trochanter, don't damage the posterior wall of acetabulum. Once you have exposed the acetabulum, have 360-degree exposure, remove overhanging osteophytes, expose the floor, remove biofilm, remove the biocartilage, fibrous tissue, etc. Carefully inspect the acetabulum for any breach in the floor, and after exposure, do peripheral reaming. You need to do peripheral reaming. You don't ream the floor, preserve the subchondral bone, and once you have done so, again inspect the floor for any breach. You have to be very careful in reaming. Don't ream the medial wall. Prepare bone grafts, about 8 to 10 millimeter size bone grafts. Sometimes you need a chunk as well. And you prepare the acetabulum, and then you carefully and gently impact your bone graft, or do a reverse reaming. Prepare a socket. Put a trial. You may require image intensifier. I use transverse acetabular ligament as a guide for anteversion. You put one size less for the feel of socket, or sometimes you can put the real size. It should fit nicely at the periphery. You can see in the video. Once you are satisfied, one can see I'm shaking with the handle. It is so stable in the case of protusio. Once you are happy and satisfied, put your actual cup. Preferably use enhanced porous cup. And if you're using so, aim for at least 50% of contact. Fit the cup at the periphery. I'm showing in the video, it is very stable. You can shake it up. And for a poor quality bone, you can choose 1 or 2 millimeter size bigger than the last reamer. And if you're not happy with the stability, and I always use multiple screws for better stability, especially once you have grafted the acetabulum, you feel much safer. One example, the head is up and out and up and in, and the structural graft put at the top, and the cup was brought down, and adequate lateralization was achieved. Another case, severe protrusio, there was no defect in the medial wall, a structural graft at the floor, and multiple mossless graft above that, and then we could restore cup lateralization, achieve center of rotation, with adequate lateralization. This is preoperative, and on the right is postoperative. You see, it is immediate postoperative. You can see the staple, but see the bone graft, it looks consolidated, immediate post-op even. 2 months follow-up, and again 8 months follow-up. Patient is doing very well. It's almost now 5 years. If the bone is very osteoporotic, think of a cemented cup. There is no harm in putting a cemented cup, and if along with the cemented cup, one can add bone graft if there is protrusio. Medial bone grafting works very well. In case of breach in the floor, you need to use protrusio support devices of your choice. Showing one example, a pulmonologist doctor with tuberculosis, 11 months follow-up. One can see it's the so-called wandering acetabulum, medialize and going up. CT scan showing the floor defect. We use enhanced porous cup along with grafting, and this is 7 months follow-up. If you see, it is 2013. The doctor is doing still well. So enhanced porous cup on the femoral side, we used Esrom for playing around in the anteversion if required. What are the results of these bone grafting and use of these cups? The routine cups as well. Few larger studies. This is total 148 hips, 18.3 years. Better results with bone grafting. There are 3 slides more only. 53 patients, 15 years, cup survival about 90%, 85 to 90%. Again, a review article from India. Survival is about 70 to 90% at 15 years. Very important, is restoration of hip center mandatory for total hip arthroplasty for protrusio acetabular? It says implant stability and favorable results were obtained by press-fitted cups irrespective of hip center restoration. One can opt for higher hip center, only thing you don't lateralize. Similar found in CDH patients. There is no obvious difference. Thank you very much.
So I invite Dr. Vijay Kumar for his talk.
First of all, I would like to thank Dr. A.S. Prasad. It was very grateful of you to call me again. I have been here pre-COVID. It was a very wonderful experience. And everybody else associated with this course, thanks a lot for having us here for an excellent academics and hospitality. May I have my slides, please? Yeah. So I'm going to talk on, it's basically I was asked to present a video. It's a video presentation on acetabular defects. So I'm going to show you, how to put an femoral head with the cage and an augment also and a 3D printed implant. So this I'm not going to elaborate in detail because Dr. Aninora has very beautifully demonstrated how to take care of protrusio. So the other type, this is how do you put a femoral head? So if you see there's a big defect there, so you put in the head and then you need to shape the head according to the defect, take out the cartilage along it, try to place it there, and then it's usually posterior superior defect. Provisionally hold it with 2 KYs, right? And then once it has been hold on, then you put some partially threaded canceller screws. Usually you have to put 2 screws, it would not rely on 1, and once the screws are in, you have fair amount of stability. It decreases the size of your cup also. Then you start reaming, and the advantage with bone graft is that you can ream on that, and depending on the graft, and the bone there, you start reaming, and you come to a size which will take in the cup. If it's a revision situation, you use trabeculometric coated cups like a Greption cup or a TM cup. In this case, the patient had a big protrusio also, so we used a cage. So this is a trialing for the cage which is being done. You put in a mossless graft there, and then you put in this cage. This is a cementless cage. It comes by the company which is called as a from link. It's called as a combi R cage, and it's got a hook which goes into operator foramen and has flanges which are fixed on the ilium with screws. So putting it, the cage, you first put it in the operator foramen. Once it gets a hold there, then only you can use the introducer, not before that. And you need to, bang. So it restores the center of rotation. So you need to be very, very careful. And then, once it is secured below, then you can use the impactor and try to push it in. So, and if you're using a graft, femoral head graft, it's very wise to support it with some sort of, plate or a cage if it's a revision situation. Graft alone would not be very successful. And once you have some amount of stability, most of these revision cases with defects, the cup usually is, put in with hand most of the time. So the first screw that you put is in the dome. So once you have that screw in, and then you can put, this cage allows you to put 4 or 5 screws in the acetabulum, and in the flanges there are another ability to put around 6 or 7 screws. So this is the screw which is being drilled for the first screw. This is the most important screw. Once you have the screw, then you again assess the position of the cage. Once that has been put, then you put screws in the flange. There you can bend the flanges also, and this is the liner. This is cementless liner. It has snapped inside, and it's got around 20-degree posterior elevation and around 4 or 5-degree elevation all around, and this is the final surgery which is done. So this was an example of using a cage along with a graft. So next, I'm going to show you how to use an augment. So here, if you see, there's a graft there. There's a defect posterior superiorly here. So you put in the with an augment, you can put in the augment first and then put in the cup, or you can do it the other way around. If you have some stability, put in the cup and then put in the augment above. So the augment can be used. So this is an augment again. So you do a trial and then put the augment there. Now again, augment can be used in 2 ways. One is as a bone graft, and second is for the reduction of the size of the cup. If it's used as a size of reduction of the cup, then you do it the same way as I showed you the femoral head graft. So in this, it is used as a graft sort of thing. So you put it in the superior side. Then the augment always has to be secured with a couple of screws, and it has to be unitized with the cup. So if you see, I'm putting in the screws, but the screws are not fully tightened. So so they are not fully tightened, and then you put in cement in between the cup and the augment and over the augment, so that it becomes a single unit. And then once the cement is about to set or has gone in, then you can tighten the screws there. So then the final tightening of the screw is done after that, and then so here, so this is tight. So it becomes a single unit along with the cup. So this is how it is. Right. So this is how it is. So if you see, the posterior superior defect has been taken care of with the augment, right, with the cup. So I guess these are 2 examples of similar failed revisions in which an augment has been used. So the third is sometimes you require an augment will not take care, so you require a buttress. So these are also defects there. So type 3C, 3P and 3C defects. So there's a big posterior superior defect. There's hardly any place to even put an augment. So here the buttress helps in, because the buttress, you put in screws on the ilium, and the lower part, it's right and left separate. So it helps take care of the defect there. So the buttress has been put in, and then you put in here. These buttress comes only by Zimmer, and they are we always use it with the TM cup. So you put in a cup there, and then this is the final liner. And this buttress also needs to be unitized with the cup. So this has been unitized using cement, and this is the final construct. So this is how a buttress has been used in this case, right? So the last, I'm going to show you how do you use a 3D printed cup. So this is a case which had no posterior wall, posterior column, and this is a 3D printed implant which we had made. So the important thing in this is that your dissection has to be to the bone. So the bone, because this is made to be snugly fitted with the bone, so they give you some jigs also to do some provisional reaming. So they give you a plan, you do it accordingly. So this they also give you a pelvis along with the template. Here you can see how it is like, and then the most important thing is to, the juggling in to put in the the 3D printed cup in. So sometime it takes a lot of time to figure it out. Then, you need this intraoperatively as an assistance. And once it is there, it is rock solid. Then you can put in screws. So they give you the screw lengths. They are locking screws also, which are giving in the periphery of the cup, which helps you hold the cup further. And they give you the screw lengths and the screws also, and the direction in which this needs to be put in. So these 3D printed cups, once this has been implanted, so you put in a cemented liner onto it, or a cemented dual mobility. So here I am cementing a dual mobility insert. It's from Evolutus. This cemented dual mobility cup comes in. So you put in the cemented dual mobility cup in this, and the final version in which you want to put it, you can even change at this moment. So here you're cementing in the dual mobility cup. So you do it, you take out all the cement, and so this is how it is. So this is the final reduction which is being done. Okay, so this is the cemented the 3D printed cup, which I think I did in the last week itself. So I thank you for your attention, and I would like to invite you to our annual meeting, which is the current concepts in arthroplasty. This is in the last week of July. I thank you for your attention.
Thank you, sir, for the nice presentation. Dr. Pankaj Agarwal to be invited on the stage for his talk on role of impaction bone grafting in total hip replacement.
Good morning, all the respected faculty members and the delegates. And I would like to thank Dr. Prasad sir for giving me this opportunity. I'm going to speak about role of impaction bone grafting in primary total hip replacement. So it was first described by Hastings in 1975 and later on popularized by Sloof et al. In 1984. Bone graft can be impacted into contained defects, or they can also be used in defects that can be contained to create a stable bed. It can be used for both cavitary and segmental bone defects, and the bone defect, this graft works by getting incorporated by the method of creeping substitution. So what are the objectives of impaction bone grafting? To restore the bone stock for future revisions, especially important in younger patients, restoration of the anatomical hip center, and to provide a stable stabler component. So the primary indications are, in primary THR, the indications are protrusio stabili, Peprosky type 1 and 2 stabler defects, and AOS cavitary or less severe segmental defects. So this classification is talked about. So type 1 is AOS classification. Type 1 is segmental defects where the rim is damaged. Type 2 are cavity defects where the rim is intact. And type 3 is combined segmental and cavity defects. Type 4 is pelvic discontinuity, and type 5 is fused hip. So it can be used for type 1 to type 3. Type 3 with the lesser severe cases. So going by the Peprosky classification, depending on the amount of proximal migration of the femoral head, type 1 there is no migration, type 2 is there is migration is less than 2 centimeter. So impaction bone grafting has been shown good results up to type 2. In type 3, the failure rates are high with almost 22% survivorship at 10 years. So it is recommended for lesser severe defects, type 1 and type 2 Peprosky. So the technique, coming to the technique, one must achieve a bleeding bone bed on which the impacted bone can go and get incorporated. Femoral head autograft can be used, even allograft can be used. All the cartilage must be removed and all the soft tissues must be removed. And if the host bony bed is sclerotic, then one can put multiple drill holes so that the bone starts bleeding. The ideal size of the cancellous chip should be at least 8 mm to 10 mm, so it should be a crouton, not a slurry. And the graft has to be impacted firmly in layers. So recommended is 110 blows with a 7.5 kg hammer. and the graft should be so hard that it should feel like a cancellous bone after impaction. And this is debatable, one should avoid reverse reaming as the shear forces can lead to dislodgement, destabilization of the impacted graft, and the cup should be placed lateral to the collos line. And whenever we are using uncemented cups, screws should be used to hold the cup. So these are the size that we would typically want. So this can be achieved by using the autograft femoral head or allograft, and one should use bone nibblers to make these large 8 to 10 mm size graft particles. And one should assess the depth of the cavity and the amount of layer of bone that has to be recreated, and then impact the graft in place. So what are the factors that are affect the incorporation of the graft and the outcomes are favorable factors are primary total hip arthroplasty has shown better results than revision total hip, use of autograft, use of cementless cup has shown to be better than cemented cups. Then lesser grades on Peprosky and AOS classification decrease thickness of the graft layer. If the graft layer thickness goes more than 2 centimeter, then the results of the chances of failure are higher. If the defect is contained, then definitely impaction bone grafting is a good procedure. And in case of segmental defects, then it has to be augmented with a porous metal augment or a wire mesh in conjunction with the impaction bone grafting. So what are the alternate options? The alternate options would be to use a jumbo cup, or in cases of old or morbid patients, one can use cement to fill the defect, but of course the longevity is not that good. So sharing a few cases, this is a 38-year-old male patient who presented with a 2-year-old hip trauma, complaining of pain and limp while walking, restricted range of motion, 1 centimeter of supratrochanteric shortening. So these are the x-rays. The patient had a protrusio and a slightly superior migration also. So basically up and medial and superior defect. And as we can see on the CT scan, there is a protrusio and the column seem to be intact. So this patient was managed by simple bone grafting and a standard stabular shell and 2 screws. And this is the immediate post-op X-ray, and this is the X-ray at 1 year. And this is the video of the patient walking without any limp or any pain. Another case, 1-year-old hip trauma, patient was managed with acetabular plating elsewhere, presented pain and while walking and limp. Range of motions were fairly preserved, there was no shortening, no deficit. This patient presented like this with hip pain. So these were the CT scans which showed that the acetabular fracture had healed in the malunited position and managed by impaction bone grafting. This is the mid post-op X-ray, and this is the X-ray at 2 years, and this is the gait of the patient walking without any limp or any pain. Another case where there is a superior and middle bone loss, there is shortening. This is how the patient is immediate post-op X-ray and 4-month post-op X-ray showing a united impaction bone into the place. Rehab, so 6 weeks partial weight bearing followed after 6 weeks full weight bearing can be allowed. Contraindications, presence of infection, recent history of local radiotherapy or severe bone loss. So the take-home message, impaction bone grafting is a reliable biological and mechanical method to restore bone stock. One must do a X-ray and CT scan to identify the type of defect, and it is preferable to use autograft. The graft size should be at least 8 to 10 mm and firm impaction of the graft should be done. Weight bearing should be delayed. If it is a simple cavity defect, then impaction bone grafting alone can work, but if it is a segmental defect, then metal mesh rings or cages are to be required to augment the to cover up the defect and make the uncontained defect into a contained one. Thank you for patient listening.
Thank you, Dr. Pankaj. Dr. Ajay Bharti to please come on the stage to present his talk on management of acetabular defects.
Respected chairpersons, a very good noon to all of you. And at the outset, I must congratulate Dr. A.S. Prasad and his team for organizing such a wonderful academic feast. and I'm really grateful to him to giving me also opportunity to express my work to this esteemed gathering. So I'll be talking on management of acetabular defects in THR. Although a lot have been told, so I'll be very specific and try to contain it within time given to me. So greetings from AIIMS Gorakhpur. So the causes of acetabular bone loss: long-standing primary or secondary OA hip cases, which are neglected, and protrusio acetabular, which we usually encounter in inflammatory arthropathies, major defects arising out of pelvic and acetabular fractures, and majorly the failed primary THR and sequelae of infective arthritis. So if we consider what are the major causes of acetabular bone loss in primary THR which has failed, so with the paper I have come to know that dislocation and instability are the most common causes which would lead to acetabular bone loss. Aseptic loosening second, infection is third, periprosthetic fracture fourth, implant failure fifth, and other causes which include dissatisfaction by patient, pain, and combined causes. And total hip arthroplasty is also projected to increase between 43% to 70% by 2030 in comparison to 2014. And so the armamentarium is that we would have to face a lot of revision THRs. So what are the preoperative evaluations which has to be done? Foremost is the nutritional status, anemia, chronic diseases, smoking, vitamin D deficiencies, and osteoporosis. Second is the inflammation and infection, which usually we find out through CRP, prolactin, and interleukin 6. If in doubt that there is some infection, we must go and aspirate the joint. For preoperative evaluation, for radiological assessment, so these are the bony landmarks which we must understand and we must keep it in mind. And for giving this, we must take Jude views and APN lateral views. CT scan done for evaluating the type of bone defect so that we can fit it to a classification. Magnetic resonance imaging to assess the quality of the local soft tissue around the acetabulum and the quality of the abductor complex, and CT angiography for the vessels. So although the previous speakers has already emphasized on the classifications, I'll be skipping those. So presently Paprosky classification is widely accepted and it provides basis for implant selection. So in type 1 uncemented porous coated, type 2, type B same thing, but with some change in selection of implant with multiple screw holes or rim fit with multiple holes. And in type 3A and 3B, we need to have some kind of augments to fix these bone voids. So in Paprosky type 1, there is some medial defect, rim is intact. In type 2A, superiorly rim is deficient, but still intact. In type 2B, there is segmental loss of the rim. In type 2C, there is loss of medial bone as well as the rim is also somewhat involved. In type 3A, it is superior-lateral defect, and type 3B, it is superior-medial defect without pelvic discontinuities. So there's a case, 54 years female with rheumatoid arthritis, managed elsewhere, presented with pain for 6 months and inability to bear weight for 2 months. So these are her x-rays, AP Jude views. There is a dislocation of acetabulum along with the head, and acetabulum is placed more medially and superiorly. So a CT was done to assess the defect, and a CT angio was defect seen there. So there was, we will little bit skeptical about where is the vessel lying. So we kept it in our mind to what to do, and then with posterolateral approach, we removed all the implants except the femoral stem. So we placed, one slide is missing, I suppose. So we placed this burst induced cage construct, reinforcement cage, and cemented a dual mobility cup. In a case 2 of similar with fracture pelvis with column deficiencies, T type of fracture was there. In the single stage, it was operated by plating the posterior column and placing a jumbo cup. In a similar type of case 3 with bilateral protrusio et stabili in case of bilateral AVN. So impacted bone grafting and a large size cup was placed. So for these are the implant range which are available for managing 3A defects: cemented cup with cage, structural allograft with highly porous hemispherical cups, impacted bone grafting, jumbo cups, custom triflange, and TM augments with hemispherical cups. So in our armamentarium for 3B, a lot of implants are available through Zimmer and other companies: trabecular metal cup cage, shim augments, octopus cup, MRP Titan, and reinforcement cages. Thank you.
Thank you, Dr. Ajay Bharti. The house is open for